kind of work our way here through the lower extremities up to the shoulder, and I will be talking about evaluation management of hip pain, trying to inform you about some of the newer thoughts about hip pain and some new diagnoses that might be of interest to you that you may not be aware of. I think the most important thing is to recognize what is hip pain, where the symptoms of hip pain originate. And I think probably the most key factor is that hip pain is generally a groin pain. Many of the patients will think they have a groin pull or they strained a hip flexor or something like that. And the way they will often display that to you is by cupping the hip when you ask them, where are you feeling your pain? And we call that the C sign. I don't know if it's the C of the hand or the C of the arm here, but the C sign is a very important thing for me when I'm evaluating hip pain to determine that the source of the pain is the joint, rather than the common things that patients will say like when they come in and say their hip hurts and they point back here. They'll point to their low back or perhaps their buttock. And those are rarely places of origin for hip pathology. On X-ray, I think there's obvious times when there's hip arthritis, bone-on-bone contact, the ball and the socket are in direct contact, the bone is sclerotic and there's cysts. I think then we know that there's hip arthritis, and that's a pretty straightforward issue to deal with. But then we get into these X-rays where the hip joint space remains clear and looks normal, and I think that a lot of us would say these are normal X-rays. But to my eye, they're not. And I think there are subtle differences here that can make a big differences in patients who have hip pain that sometimes even radiologists don't recognize. And I think if you look very carefully, you can see a fullness of the femoral head and neck here, whereas here it comes down and curves down nicely. And those are signs to me that there may be soft tissue pathology in this hip that you can't see by plain X-ray. And that comes up to the anatomy of the hip. I think the articular cartilage on the ball and in the socket or acetabulum are fairly well understood, but the soft tissues around the hip are very potent generators of pain, and in particular this structure here, the labrum, which is a fibrous ring that surrounds the socket, intimately applied to the bone and attaching to the inner part of the articular cartilage in a very dynamic manner, and it forms a seal in a gasket-like manner for the hip joint. And diagrammatically and anatomically, you can see the labrum attaching intimately to the bone surrounding the acetabulum, but it also attaches to the cartilage on the inside of the acetabulum. And you can see that here pretty well on the anatomic specimen. So a labral tear is caused by either degenerative conditions or by anatomical issues. And it is a cause of pain, catching and locking in the joint. Symptoms can be activity-related, they can be rest-related, but these tears, even very small ones in my experience, are associated with quite a bit of pain and dysfunction. So that's just an instance of how a labral tear, the labrum can separate from the acetabulum. So different types of labral tears exist. You can have just degenerative fraying of the labrum, kind of like a meniscus. You can have separation of the labrum from the bone. And this is a fairly common appearance of a labral tear. Here's an arthroscopic image with a probe going into a tear. That's the labrum around. That's the depth of the socket with the articular cartilage. And you can see the labrum is separated from that. And even that 1 centimeter distance there produces quite a bit of pain with activity. So it brings us to the concept of what causes these tears. And anatomically, that is our new concept, or relatively new concept, of hip impingement. Hip impingement is the result of bony abnormality around the hip joint. We have two types of abnormality, one called cam impingement, where the femoral neck is enlarged and does not clear easily into the socket. The other is called pincer, where the acetabular edge is overgrown and hanging over the side a little bit too much, so as the hip flexes up, actually the acetabulum impinges onto the femoral neck. This produces pain with activity. Running flexion activities, repetitive flexion activities produce pain. Sitting can produce pain. Rotational motions can produce pain as these bony prominences hit against each other. On these diagrammatic views, in a normal situation, the femoral head with flexion of the hip will clear into the acetabulum with no contact whatsoever. But with pincer impingement, with enlargement of the acetabular rim, the acetabulum will hit against the femoral neck, the anterior part of the femoral neck, pushing the femoral head into the back of the acetabulum with a levering type motion. With cam impingement, the bump in the front of the femoral neck as it comes up into the socket actually pushes against the labrum and the acetabular rim every time it comes in to the socket in flexion. So let's see if we can get this movie to, can you get the movie to start? Maybe. Maybe just click the image. All right. All right, that's okay. Those are just movies showing the impingement process with hip flexion. So here's normal x-rays. Normal appearance of the femoral head and neck position, normal clear space between the acetabulum and the femoral head. A lateral view, you can see a nice curvature of the femoral head into a hemispherical, almost hemispherical shape on the lateral view. In cam impingement, on the AP view, we'll often see a fullness of the head-neck junction here to the lateral side of the femoral head. And on the lateral view, here's 3 different laterals of cam impingement. Very subtle fullness of the anterior aspect of the femoral head-neck junction rather than the normal curvature which we see on the posterior side. We call that loss of offset of the femoral head-neck junction. Pincer impingement is much more difficult to see by X-ray. You need to be able to determine the posterior acetabular wall and the anterior acetabular wall on an AP view. And when there's pincer impingement, we call this the crossover, where the anterior wall, this white dotted line, crosses over the posterior wall, the black dotted line. Normally they should meet at the same point here at the side. When the anterior wall crosses over, it means that this much bone is overhanging anteriorly, which is a sign of pincer impingement. Pincer impingement processes are treated by hip arthroscopy. They're treated by open hip dislocation. My preference is hip arthroscopy. This is a procedure we do offer, surgeons do offer at Tri-City Medical Center and our surrounding outpatient surgery centers. It's done through small incisions around the hip. We can treat labral tears, we can treat impingement, we can treat bony impingement, and we can do this all on an outpatient basis with 2 or 3 small incisions. Candidates for hip arthroscopy are expanding. I think the most important thing is, the most common thing we see are labral tears and cartilage injuries due to hip impingement, but we can treat loose bodies, we could treat ligamentum teres tears, bursitis issues around the hip, trochanteric bursitis, iliopsoas bursitis, all can be treated arthroscopically. Which brings me to some of the extra-articular causes of hip pain. Very commonly in our elderly female population in particular, trochanteric bursitis is very common. Pain to the lateral side of the hip with tenderness right over the greater trochanter of the femur. We also have the snapping hip syndromes. Internal snapping hip is a catching in the groin, popping with flexion and external rotation of the psoas tendon. External snapping hip is a relative of trochanteric bursitis. It's the iliotibial band laterally snapping over the greater trochanter of the femur. And more commonly now in our young athletes, soccer players, basketball players, football players, is the sports hernia, which is a tear or tearing or avulsion of the rectus femoris insertion off the pubic tubercle. Internal snapping hip is, as I said, the psoas tendon, which runs right across the anterior aspect of the hip joint. It can be pain and snapping with flexion, extension, and external rotation of the hip. This can be treated surgically, but I'll tell you it's like 1 a year that I have to treat surgically with release of that psoas tendon. The vast majority of these cases are treated with stretches, with physical therapy, anti-inflammatory agents, and thankfully our interventional radiologists are very good at injecting this under ultrasound with cortisone. Trochanteric bursitis, similarly, it's a pain to the lateral side of the hip. pain with walking. They can't lay on this side. It's tender to the touch, which is a very differentiating factor for many of the hip pain syndromes we've been talking about. This one is tender and palpable. Again, easily treated with anti-inflammatory agents, cortisone injection therapy, stretches are very successful, and there are arthroscopic or endoscopic ways of treating this as well, but again, fairly rarely needed. So when the hip becomes arthritic by x-ray and there's groin pain and pain that interferes with daily living, standing, walking, quality of life, options become more limited. Arthroscopy is not an option for the arthritic hip. And I think Dr. Helgager will echo that for the arthritic knee. But total hip replacement then becomes the surgical option. This is becoming a very common operation, over 300,000 done in 2012, and it's going to continue. And I think most of us that do joint replacements are finding that we're doing them more and more in people under 60 years of age. The 50 to 60-year age group is becoming very prevalent now with total joints, whether it's knee or hip. The good news is it's one of our best operations that we do for returning quality of life. 96 to 98% good to excellent results, satisfied patients, happy with their result, and a return to quality of life. So hip replacement is a procedure in which the arthritic ball is removed and a metal piece placed into the thigh bone with a metal or ceramic head placed on that, and a metal piece is placed into the socket with a plastic liner. And that is the procedure that relieves the pain. It can be done in a number of different ways. There's posterior approach, anterior approach. There's lots of different methods for doing it, all with excellent results. In younger patients, while this is a total hip replacement here and here, this is called a resurfacing arthroplasty. This is something we now reserve for our younger, very active patients who have hip arthritis. It is a metal-on-metal component. It preserves bone stock. As you can see, the entire femoral neck is still present, and this metal ball simply caps the top of the femur. So in this situation, we preserve bone for the future, and because the native femoral neck is present, we can even allow these patients to return to vigorous activities, sports and running and jumping and things like that. In this situation where the entire weight-bearing load is placed on this prosthetic component up here, and there's a metal and plastic bearing surface, we tend to restrict activities to avoid impact for the long term to get this to last as long as possible and get the bone of the upper femur to last as long as possible. There's a little slide about, you may have heard about anterior and posterior approaches. In the end, I think that surgeon's preference on the approach to hip replacement is simply that, it's surgeon's preference. In the end, there are really more similarities than differences to them, and results are uniformly excellent regardless of which approach is used. We do the same things for all of them at the time of surgery. We recover them the same. There's some subtle differences in literature regarding certain risks of dislocation or limb length discrepancy, but those are small. They're real in my opinion, but they're small, and those are the only places where I can say at 6 months out if there's any difference between an anterior or posterior approach. Gary?
With the partial hip replacement, patients always ask me how long this hip replacement is going to last, because I've always tried to get them to postpone it as long as possible.
Yeah.
Partials, how long?
A partial hip replacement or a total hip replacement?
The partial.
The Birmingham, the resurfacing you're talking about? We don't have an answer to that, and I think the answer I give patients is 15 to 20 years, which is exactly what I give for a total hip replacement. I think it can be longer. The metal-on-metal bearing surface can actually potentially last longer. But we don't have data for 20 years yet, but I would guess 15 to 20. I tell them 15 to 20 years. And the whole discussion about waiting for hip replacement, the discussion I often have with patients now is about quality of life, because the active years wane fairly quickly after 55 or 50. You're going to be active till you're 70 maybe, and you can take those years and limp around and be painful and stick it out so you get a hip replacement or a knee replacement when you're older. Or it's a philosophical thing that a patient has to answer for themselves. Or do you want to get this operation done now and be able to enjoy your active years without the pain and be able to travel, be able to dance, be able to hike, be able to surf and do the things that you've had to cut out to make things last longer. And by the time you're 70 or 75, you may not want to do those things anyway. So it's a philosophical issue that I let the patients decide, but I have that discussion with them.
And how about in the metal-on-metal prostheses, dangers of chromium and heavy metal leaching?
That is the reason why I think at Tri-City Hospital and most hospitals around that the metal-on-metal implant selection has diminished to about zero. The only metal-on-metal implants going in, I believe, at Tri-City right now are the resurfacing arthroplasties in the young patients. It is a definite risk. There are reasons for that, and the metal-on-metal implants have been associated with a lot of problems at the prosthesis itself, with metal debris around the prosthesis, reactions of the soft tissues, which are very severe. I mean, destruction of muscle and tendon, and when you reoperate on some of these patients, there's nothing you can work with, soft tissue-wise. So it's a reason that most of us have moved away from that and back to our metal and plastic origins, which are very good. Dr. Lafata?
In an otherwise healthy person, do you have an age cutoff beyond which you would not want to do a hip replacement?
Older or younger?
Older.
I don't put any age restriction older, ever. I think that's a patient choice, and if the patient has made it to 90, they're probably a proven survivor already, and probably if they're coming into the office complaining about their hip hurting and willing to have an operation, they're probably in pretty good shape to begin with. And even if they're not, I have an internist talk to them, I have a cardiologist talk to them, and if they're willing to accept the risk, if their life is so miserable for the remaining 6 months or 6 years at 95, whatever it is, that they are willing to put their life on the line to feel better, I go along with them. Dysplasia. I put beware of dysplasia. These are these subtle changes on x-ray, normal joint spaces, but shallow acetabulum. This acetabulum should come over and cover that ball better. These are very subtle changes on an x-ray that are warning signs to me as an orthopedic surgeon, and I think if you see dysplasia in an otherwise normal film on one of your patients with hip pain, if you see it or a radiologist notes it, that's something that you got to be aware of, because that's a patient that's going to have trouble down the road. And if it's started, if pain has started, they're on their way. And that could be 25 years old, it could be 45 or 50 years old. But the young patient with dysplasia and pain is starting down a bad road, and so that person needs to see an orthopedic surgeon more quickly rather than later. So finally, just kind of how to work it up and what to do. Determine that it is hip pain first by the location of the pain in the groin. Determine if it's bursitis, trochanteric bursitis by palpation. Is it a snapping hip syndrome, or is it internal labral tear snapping in the groin? Check examination, look for tenderness. The impingement test is flexion of the hip with internal rotation at the same time producing pain. Very commonly produces pain with arthritis, but in a normal x-ray it shouldn't produce pain. Range of motion limitation, also very common in hip arthritis and impingement syndromes. X-rays, very simple, just an AP of the pelvis and a lateral involved hip. You don't have to do more than that. If orthopedic surgeons decide they want some more extensive views, that can be done at the office. Then, as with most orthopedic conditions, conservative care initially is the way to go. This often gets people controlled for a long period of time, anti-inflammatories, Tylenol, physical therapy sometimes. What you'll find with impingement patients is you send them to therapy and they get worse because the therapists are trying to push their hips and get them moving, and so oftentimes that makes them worse, but it's worth a try. Local anesthetic injections under fluoroscopy. You cannot inject a hip joint in the office without some sort of imaging device, whether it's ultrasound or fluoroscope. You have to be sure you're in the hip joint when you do it. So I send the patients to the hospital for fluoroscopic injections. And cortisone injection therapy for arthritis is certainly an option. And it's also an option in other joint-related pains, just to see if people can get benefit for a period of time. I wouldn't do a cortisone shot more frequently than every 6 months into a joint. And then finally, see an orthopedic surgeon for radiographic abnormalities or pain that's not responding to conservative care. Yeah, Marty.
How many cortisone shots do you allow? Very often here, you do a little more than 3.
I don't have an upper limit for someone who's getting by with shots every 6 months or more. They can do that for as long as they want. I think there's a couple of things. Once you need them more than every 6 months, the shots are kind of helping, but they're not working. And the other thing is cortisone is particulate. It's a particulate injection, and it also softens joint cartilage. So you're putting basically microscopic ball bearings into a joint that's with a substance that's softening the cartilage. And if you're doing it repetitively, you just wear down the joint quicker and quicker. So it gets worse and worse. There are some doctors that do it every 4 months, but I'm fairly careful with it. I go 6.
So the replaced hip in the last 15, 20 years, if you did it in a younger individual, what do you begin to see when it's starting to break down or fail, and how do you handle it?
I think the first thing you notice is your patient who had been pain-free and doing great and enjoying their new hip becomes painful. Again, and it's groin pain, thigh pain. Groin pain usually associated with acetabular component loosening in the pelvis. Thigh pain associated with femoral component loosening in the femur, very commonly. And X-rays is the first starting point. Anti-inflammatories can help quite a bit with that and get people by for a while. But once components start to loosen, it's just a question of time before it needs to be revised. I always work up a painful joint replacement, whether it's knee, hip, shoulder, whatever it is, for infection, because that can happen in an indolent fashion. So CBCs, SED rates, C-reactive proteins, and I'll often get bone and white cell scans in addition, because that will help loosening versus infection. And
When you revise, when you do a revision hip arthroplasty, what's your expectation of the outcome in terms of how they're going to do?
I don't think any revision is ever as good as the first time around, but in the hip we have pretty good results, and I'd put them in the 90+% good to excellent result range on a hip for a revision.
And someone with a labrum tear, doing arthroscopic surgery, what's the time to return to normal physical activities in an active person? And do they usually end up pain-free?
It's a very rewarding operation in my experience. I see patients who have had hip pain undiagnosed for a year or two or more because there's not a lot of awareness of the condition. And after hip arthroscopy, they are very, very grateful. They can tell a difference within a week or two that their hip is different, even with surgical pain. But it's a very long recovery. I tell people to expect 4 months before they're back to sports and activities. You do a hip replacement on somebody, they're back to activities, walking, work, 4 to 6 weeks out. So it's quicker to recover from a hip replacement than a hip arthroscopy. But it's worth it to preserve the joint, especially in the young patient. But I think excellent results are achievable. We don't, from data in terms of long-term data on hip arthroscopy and labral repair and impingement surgery, we don't have more than 5-year good follow-ups at this point. But the 5-year follow-ups are all still looking like it's going to be very durable. So.
If someone doesn't have pain, but they have snapping or instability, is it better to operate on them so they don't have long-term arthritic change, or don't operate if they don't have pain?
I don't treat X-rays and MRIs and things like that. I treat the patient. So in my opinion, radiographic abnormalities that are asymptomatic are to be left that way. My goal is to make someone as pain-free as possible with what I do, and if they're already there, I can't improve on that. So I don't operate on asymptomatic findings. However, the patient knows they have it, I know they have it, and if it does become symptomatic, they're very aware of it, and they will usually come back if it becomes symptomatic.